5B. Okay, so the question goes, a 27-year-old man weighs 127 kg, height of 165 centimeters, presents with exertional dyspnea, no cough, smokes 10 sticks daily, not asthmatic, no family history of hypertension, DM, COPD, cancer, lung function test showed restrictive pattern. What is the cause of his symptoms? What investigations will you do to make the diagnosis? How will you manage? What are the health consequences of this condition? Sorry. I'm sorry. Sorry, I'm trying to share my screen. Okay, sorry. Okay, so let me just go back. All right, so the question goes, so a 27-year-old man weighs 127 kg, height of 165 centimeters, presents with exertional dyspnea, no cough, smokes 10 sticks of cigarettes daily, not asthmatic, no family history of hypertension, DM, COPD, cancer, lung function test showed restrictive pattern. What is the cause of his symptoms? What investigations will you do to make the diagnosis? How will you manage this patient? And what are the health consequences of this patient? Okay, so basically, the key notes to take note of are, is a young male. He has a BMI of 45.4 kilograms per meter square, placing him in obesity class 3. He has exertional dyspnea, smoking history, and a restrictive pattern. So that gave it away to obesity hypoventilation syndrome. Why? Because it's commoner in the males, and then mostly their BMI is more than 40 kilograms per meter square. The exertional dyspnea most times is attributed to daytime hypercapnia and hypoxemia. And then they have a restrictive lung pattern. The restrictive lung pattern has been attributed to when there's adipose tissue around the lung tissue. So basically what happens is that it restricts the air from going in, and then what happens is that the lung compliance is blunted in this patient, giving this patient a restrictive lung pattern. So, okay, so this is basically what the patient has. The patient actually has obesity hypoventilation syndrome. Okay, so another name for obesity hypoventilation syndrome is Pickman syndrome. And then it's said to be defined as presence of awake alveolar hypoventilation characterized by daytime hypercapnia of greater than 45 millimeter per mercury that is thought to be a consequence of diminished ventilator drive and capacity related to obesity in the absence of an alternate respiratory, neuromuscular, or metabolic explanation for hypoventilation. So basically, obesity hypoventilation syndrome is a diagnosis of exclusion where we have to exclude respiratory causes, neuromuscular causes, and also metabolic causes for their hypoventilation. So this is a triage of obesity hypoventilation syndrome. So now the next question is, what is the cause of this patient's symptoms? So the patient's symptom is actually exertional dyspnea. So exertional dyspnea is actually dyspnea that occurs during the daytime. It's not at night. So basically what happens is that it can be attributed to obesity from breathing mechanics. As I mentioned earlier on, from the breathing mechanics, we have adipose tissue clogged around the lungs. And what happens is that the lungs actually loses its elastic compliance. And then we have hypoventilation. And then this now brings about hypercapnia in this patient that can predispose this patient to exertional dyspnea. Then secondly, there's a blunting of the central respiratory drive. This is said to be attributed to a blunted neural response. And then leptin resistance. In obesity generally, the adipose tissue actually releases leptin. And then when it releases leptin, what happens is that there's a hyperventilatory response that occurs. But in obesity hypoventilation syndrome, what happens is that the leptin is resistant and it brings about hypoventilation. And the hypoventilation leads to hypercapnia and hypoxemia in this patient. Fourthly, pulmonary hypertension. Pulmonary hypertension has been said to occur from this hypoxemic state that leads to what? Pulmonary vasoconstriction. So in this hypoxemic state, it causes the pulmonary vasculature to constrict, and then that brings about pulmonary hypertension in this patient. So this can actually be attributed to the cause of the exertional dyspnea in this patient. Then also heart failure. It's been said that obesity hypoventilation syndrome can cause right-sided heart failure. If not treated, it can actually progress to a biventricular heart failure. So heart failure can also be a cause of this patient symptom called exertional dyspnea. What investigations will you do to actually help to diagnose this patient? Obesity hypoventilation syndrome is actually a diagnosis of exclusion. So we actually have to do a lot of things to actually exclude it. So we'll start with simply doing a pulse oximeter. This patient is actually hypoxemic. So what basically happens is that the SpO2 is less than 90%. And then when you do an arterial blood gas, to show a picture of hypercapnia of greater than 45 millimeter per mercury, and then hypoxemia of less than 70 millimeter mercury. Then when we do an electrolyte creatinine test, it will basically just show metabolic alkalosis, and that's said to be compensatory because this patient has respiratory acidosis, and then they will compensate by having a metabolic alkalosis. Then the full blood count will simply show polycythemia. The polycythemia has been attributed to chronic hypoxemia in this patient where there's stimulation of erythropoiesis to produce a lot of hemoglobin that will predispose this patient to having what? Polycythemia. Then doing a lung function test, the lung function test will just show a restrictive pattern in this patient where the total lung capacity will be reduced, the vital capacity will be reduced, and then the FEV1 over FVC ratio will be greater than 0.7%. A chest radiograph and a chest CT scan would basically just rule out the restrictive structural abnormalities in the lungs and in the heart. The ECG, the echo will rule out a right-sided heart failure in this patient, which can occur. Then we can actually do an obstructive sleep apnea probability test using the Epworth sleepiness scale. The Epworth sleepiness scale will just record the number of awakefulness sleepiness, as in episodes of sleepiness while awake in this patient, while the Berlin questionnaire would actually help to rule out obstructive sleep apnea because it tells us the number of times this patient has an apneic attack and a hypoapneic attack. Then when a sleep study, we'll do a polysomnography. This polysomnography basically will just determine the sleep apnea, and then it also determine the nocturnal carbon dioxide, monitoring also the SpO2 in this patient. This can actually help us differentiate between the central sleep apnea and also the obstructive sleep apnea in this patient, because what happens is that we can actually have an overlap of an OSA with OHS. So now also the thyroid function test. Thyroid function test will actually help to rule out hypothyroidism. Hypothyroidism can actually predispose the patient to having obesity. And we also have the class 2. The class 2 is when we have metabolic disorder coexisting with obesity. So that can actually rule out that particular class of obesity hypoventilation syndrome in this patient. The patient will also may benefit from the brain imaging. This will actually rule out the central cause of hypoventilation, like in a central sleep apnea where we have stroke, where there's an injury to the respiratory center in the CNS. So this can actually help to rule out that in this patient. Then doing a toxicology screening. So basically in this one, we're actually going to screen the patient for opioids to rule out opioid poisoning. Opioid poisoning can actually present with hypoventilation and then present in that hypercapnic and also hypoxemic state. Then we'll also do a diaphragmatic muscle test to rule out neuromuscular disease, and also an EEG and EMG. This will actually help to rule out neuromuscular defects in this patient. But aside respiratory depression, they would also have weakness in their limbs, the muscle of their limbs, and also other parts of the body as well. So now, how do we manage this patient? We'll start by taking a brief history from this patient, where we're going to establish the history of daytime sleepiness, hypersomnolence, history of weakness, snoring, nocturnal choking, and then apnea. This is said to rule out what obstructive sleep apnea, which can actually coexist with the obesity hypoventilation syndrome. Then also to rule out early morning headaches, daytime fatigue, impaired concentration and memory loss, of which they can have some form of psychosocial or mental disorder in this particular case. So we'll try to do that to rule out complications. We'll actually rule out symptoms of heart failure, left-right heart failure, and also symptoms of comorbidities. Maybe there's a background lung history in this patient, and also fruity sweet ketone breath. It's been said that 20% of the patients with obesity hypoventilation syndrome actually come down with diabetes mellitus. So we actually have to ask for that to rule out DM. Then also we'll ask for weakness generally of the chest, the neck, and the shoulders to rule out neuromuscular disease in this patient. Then also in examining this patient, we do a BMI to place the patient to know what particular class of obesity this patient is actually in. And also look out for signs of right-sided heart failure, biventricular heart failure. And then we'll also look out for comorbidities to using a mini mental state examination and also doing a motor examination. All of these will help to rule out the neuromuscular disease in this patient, as well as a lung percussion and also auscultation to rule out the background lung disease. In investigating this patient, I've actually previously mentioned how to investigate this patient. So now treating this patient, this is actually multidisciplinary, involving the pulmonologist, the neurologist, the cardiologist, the dietitians, the EDM unit, and also the surgeons, as well as the psychologists, the nurses, and the intensivists. So we have the non-pharmacological, the pharmacological, and also the surgical aspect. So for the non-pharmacological, we would advise or counsel this patient on lifestyle modification, where we actually do a weight control measure, smoking cessation, alcohol moderation, and then now going over to the breathing assistance. These patients will actually benefit from a CPAP. CPAP will actually help to oxygenate this patient because this patient actually has hypoventilation. And then what happens is that when we now have excessive hypercapnia, then we'll come in with a BiPAP in this patient. Then also when there's a persistent hypoxemia, oxygen supplementation can actually come in despite optimal PAP device. If the CPAP and BiPAP does not suffice, then what will happen is that we'll now go to tracheostomy for this patient when BiPAP and then CPAP has actually failed. So this is what BiPAP and CPAP actually looks like. They can actually wear it to sleep. So now for the pharmacological, when we have the chronic hypoventilation with poor response to optimal lifestyle modification and a non-invasive ventilation therapy, when there's a poor response to that, we can actually now resort to respiratory stimulants, bronchodilators, corticosteroids, pulmonary muscle relaxation, and then antifailure regimen if this patient is in heart failure. Then also, if there's any form of dyslipidemia, we'll give anti-lipidemic drugs, and then weight loss medications like Orlistat. If it doesn't suffice, then this patient would need a bariatric surgery. So what are the health conditions this patient is predisposed to? For the respiratory patient predisposed to type 2 respiratory failure, cardiovascular complications like hypertension, pulmonary hypertension, lungs like pulmonary embolism. The patient can actually have sleep apnea, other sleep disorders, and then CKD, polycythemia, malignancies like colorectal malignancies, psychosocial disturbances, and then non-alcoholic fatty liver disease, and also gallstones, and then some skin manifestations. I've just talked about the definition. So these are the types of obstructive obesity, hypoventilation symptoms. So we have the primary, which we can actually have an overlap of an obstructive sleep apnea in the primary obesity hypoventilation syndrome. But for the secondary, what happens here is that there's a background medical condition coexisting with obesity. Then for the idiopathic obesity hypoventilation syndrome, there's actually no identifiable cause in that particular class of obesity hypoventilation. It's commoner in males and then commoner in blacks. So basically, the pathophysiology has just 3 mechanisms where we have an impaired respiratory mechanical work due to obesity, and then we have central hypoventilation leading to hypercapnia, hypoxemia, and then there's now blunting of the ventilation with response. And then what happens is there's now acidosis and leptin drive. So this then leads to what a metabolic alkalosis, because the patient already has a respiratory acidosis. So there will now be a compensation with metabolic alkalosis in this patient. So these are just the symptoms which I've mentioned. And then so these are the differential diagnoses. For the differential diagnosis, we have the central sleep apnea, obstructive sleep apnea, COPD associated with obesity, restrictive lung diseases. So this is just basically showing the difference between obstructive sleep apnea and obesity hypoventilation syndrome. So basically everything is the same, aside obstructive sleep apnea not having hypercapnia, and then they're also not hypoxemic. So that's the difference between obesity, obstructive sleep apnea and obesity hypoventilation syndrome. So in conclusion, obesity hypoventilation syndrome is a debilitating and life-threatening condition if untreated. There's an increasing incidence of obesity hypoventilation syndrome, though still being underdiagnosed or misdiagnosed. Therefore, obesity hypoventilation syndrome should be evaluated in obese patients with witnessed sleep disordered breathing and exertional dyspnea with no other explainable cause. High index of suspicion is a key factor to prompt diagnosis. Effective treatment options are available and should be initiated promptly to avoid a long-term health consequences. Thank you for listening.
Wow, thank you so much for that beautiful presentation. Very detailed. Thank you so much. Okay, so now we'll take comments and questions from the participants. You can drop your comments on the chats, or better still, you can raise your electronic hand and make your contributions. Okay, so that was a very good one. Okay, let me take some comments on the chat first. So Dr. Iche Ojule is saying, thank you good morning all. Thank you, Dr. Florence, for a wonderful presentation. For the investigations to make the diagnosis, you can do a waist circumference or waist hip ratio in addition to the investigations you mentioned. Thank you so much. Okay. Then Dr. Ede says, thank you for the erudite presentation. Polysomnography should be okay, I guess she wants to say number one investigation, then detailed smoking history will help. How do you rule out emphysema here with a significant smoking history?
Okay, so what did you say, sorry?
She's asking, how do we rule out emphysema here with a significant smoking history?
Okay, basically we are going to do a lung function test. So the lung function test is actually going to show an obstructive pattern in this patient. So already this patient has a restrictive pattern. So that rules out emphysema in this patient. Emphysema will present with obstructive pattern instead of restrictive pattern. So that's why emphysema is not the topmost, it's not a diagnosis here. Not consider it here in these patients, or it can actually be down, but it's not topmost because it presents with an obstructive pattern.
Okay, thank you so much. Okay, this smoking history, I don't think it's significant. Significant smoking history like 20 pack years. So Dr. Blessing Amadi says, thank you for a wonderful presentation. Also note that it's called a Pickwickian. Okay, you didn't call it very well. Pickwickian syndrome. Thank you, Dr. Blessing. And then Dr. Regina says, thank you for the lucid presentation. Please, why is the index case not an OSA?
Okay, so basically, if you look closely at this patient has exertional dyspnea, meaning that this patient is breathless during the daytime or during activity. Obesity, obstructive sleep apnea actually occurs in sleep. And the mechanism actually occurs from when there's, during sleep, what happens is that the pharyngeal muscles are actually lax during sleep. And so then what happens is that we have adipose tissue around the neck. So the adipose tissue around the neck does what? It occludes the respiratory tract. That is it occludes the larynx. And then as you occlude the larynx, what happens is that they now present with that apneic and hypoapneic episode. So now what happens here is that they now have what? An arousal. As they have an arousal, they don't present in that hypercapnic and also in that hypoxemic state. And aside that, another reason again why this is not obstructive sleep apnea is because they don't have that restrictive pattern as compared to obesity hypoventilation syndrome. Obesity hypoventilation syndrome has got to do with the thorax, although we can actually have an overlap with obstructive sleep apnea. So what happens here is that the adipose tissue around the lungs actually prevents the lungs from expanding. So that's where it actually loses its compliance. So what happens is that the lungs is not being able to be ventilated properly because the lungs are not being allowed to stretch out properly. So in obstructive sleep apnea, we don't have a restrictive pattern. Rather, what we basically have in obstructive sleep apnea is the apneic effect, and also we have the hypoapneic effect, and all of these occur during sleep and not during daytime. So this one is actually occurring during daytime and then with a restrictive pattern. So that's why obstructive sleep apnea is not the diagnosis in this case, because they don't have a restrictive pattern. And then also they don't have that breathlessness during the daytime. It's at night they have that choking and obstructive symptom. So that's why obesity hypoventilation syndrome actually goes with this.
Okay, thank you so much. And then to add to that, I think them giving us his weight and height at the beginning of the question, I think they're just trying to project the obesity, because another way, so I think we shouldn't think it's too much. This is the obesity hypoventilation syndrome. Then another way you differentiate is when you actually do your investigations, the ABG, and you get that daytime that's a weak hypercapnia. So I think this is a OHS. Okay, so what are the saying? Thanks so much for your beautiful presentation. Dr. Yaya is saying, thank you for the beautiful presentation. Coronary artery disease could also be a health consequence of this disease. Thank you so much, Dr. Yaya. And then Dr. Musa is saying, thank you very much for the wonderful presentation. Stroke can be a health consequence of obesity also. Dr. Ede says, but it's said that all obesity hypoventilation syndrome, 99% have OSA. I think it's 90%, as in 90% of patients with OHS have obstructive sleep apnea also. Okay, that doesn't mean that it's not OHS anyway. Then Dr. Araga is saying, thank you, Dr. Florence, for the wonderful presentation. Criteria for diagnosis for obesity is BMI greater than 30, not actually greater than 40. Although most patients with OHS have BMI greater than 40. Florence, I agree with him. So even patients with BMI greater than 30 can also have can have OHS, and not all obese patients have OHS. Okay, so bicarbonate levels less than 27 millimole per liter makes OHS unlikely. Thank you once again for a great presentation. Okay. Okay, so what are the same things? Thanks. Okay, let me just make a little comment also. Okay, I mean, about in OSA, meals, being meal is the risk factor, but for OHS, I'm not sure about that. I'll check and put on the group. But for OHS, I don't think meal factors, being meal is a risk factor for OHS, but it is for obesity for OSA. And then just to add a little more to the pathophysiology you talked about, the first three you mentioned when you answered the question, they are actually pathophysiology, like you said, obesity-related changes in the respiratory symptoms. So because of the fat deposits around the thorax and the abdomen, especially obstructing the diaphragmatic movements, they have this reduced lung compliance, that leads to hypoventilation even during the daytime. It can also cause gas trapping and then ventilation perfusion mismatch. So that's what causes the hypoxemia and the hypercapnia that they have. And then because of this, there's an increased work of breathing. So it's usually compensated by increased drive from the respiratory centers that's in the brain. So the second part of physiology, alterations in the respiratory drive. With time, the respiratory drive may fail to maintain the respiration due to secondary depression of the respiratory centers from the repetitive hypoventilation. So then the leptin you mentioned too, very correct. Apart from leptin, normally, apart from inducing satiety, it can also stimulate the respiratory system. But because they have a lot of adipose tissue and they have very high levels of leptin, they could develop leptin resistance, where the hypothalamus will no longer respond to the leptin respiratory drive. So this could also lead to hypoventilation. And then the fact that more than 90% of them also have sleep apnea syndrome, in that the excessive deposition of fat around the upper airway can lead to pharyngeal muscle weakness and also partial or complete obstruction of their respiration, especially during the nights. So that's for the pathophysiology. Then the investigations you mentioned, you are really correct. So one other way that the polysomnography can also help you is also in directing your oxygen management. Like for those that with apnea hypopnea index greater than 30, you can use CPAP. Then for those less than 30, I think you prefer the NIV. That's the BiPAP. You can use BiPAP for them. Okay, so okay, I wanted to add that. Thank you so much for the beautiful presentation. Okay, Dr. Temi, please go ahead. Okay.
Hi, good morning,
Temi, please go ahead.
Oh, okay. Good morning, teachers and everyone. Thank you very much, Dr. Great, for the very detailed discussion on OHS. But please, can I see the question in the question itself? So, okay. Okay, thank you. So the reason why I'm asking is just like you said in your discussion, you mentioned it severally that OHS is a diagnosis of exclusion and it has specific criteria. So I know this is a recall, but based on this information is not really enough for the first diagnosis to be OHS, because without an evidence of hypoxemia or rather even hypercapnia, you can't really say OHS, because you actually listed a lot of other things that can cause dyspnea in an obese patient. So this patient is presenting with exertional dyspnea. Is not actually the same thing as hypoxemia. Dyspnea can be as a result of the mechanics of breathing, just like you said. But I'm not quite sure. Maybe SpO2 was provided and this was omitted. But just looking at this information, other things to consider is other causes of restrictive lung disease in this setting, maybe like a diaphragmatic dysfunction from the obesity, abdominal obesity, which if it goes on for a long time can eventually cause complications. So here, because OHS is a hypoventilatory lung disease, so dyspnea is usually not the prevailing symptom per se. Usually they have symptoms as a result of hypercapnia. So they can start having early morning headaches, weakness, and if it's very severe, they could come in a coma. So that also flags oxygen as being we're talking about OHS. Oxygen is going to be way, way, way down in the treatment options, because patients that have restrictive lung disease generally, they're already having hypoventilation. Oxygen usually worsens the metabolic problems and can make them worse by causing respiratory acidosis and making them unconscious. So usually the treatment is to ventilate, which you mentioned, CPAP or non-invasive ventilation. But my concern here, maybe other respiratory issues in the house, is I'm just concerned that the information provided doesn't seem strong enough to actually consider OHS. For me, I could say maybe OHS complicated with pulmonary hypertension, which will now explain the exertional dyspnea that the patient is now having. But OHS on its own, most times, till they present with complications, or if you do a routine lab and then you are noticing very elevated bicarbonate, it may not really be picked. Most times, especially if it's occurring without OSA, most times it's in the setting of OSA that we always try to exclude if there's also a coexisting OHS. But exertional dyspnea alone and a restrictive lung impairment on PFT, those two things are really not key to actually make the diagnosis of OHS. So that's why I'm concerned about the information provided. Thank you.
Oh, thank you so much. Dr. Aminu, please go ahead.
Okay, good morning, everyone. Thank you very much, Dr. Bridges, for that lucid presentation. And thank you, teachers. Just in line, it's just like Dr. Temitope, I spoke before I did. Because before you can actually go in line and say this is an obstructive obesity hyperventilation syndrome, it's so maybe you must have been able to rule out it is not obstructive sleep apnea. So she has said so much things about that. I don't want to go into that. But perhaps this is a recall, then in recall, there'll be a lot of things that might be missed out. It's just for us to look out for those points, important ones. If you are given maybe some other parameters that may be of interest, you'll be able to look into that. Then the other aspect, the issue was asked, Dr. Bridget, that how do you differentiate if there is emphysema or not? The spirometer itself, spirometry alone is not specific. It can just show restriction or obstruction, and that could go for anything. high resolution chest CT is basically what you are going to do to show what is there in the lung parenchyma, to be able to show, okay, does this person has an emphysema, okay, is there some bulle, is there some fibrosis? It's going to show much better when you do an high resolution chest CT. Just doing some lung function test could go for anything. It could go for so many things. Obstruction, underdose, restriction, underdose. So that is what I just wanted to add. Thank you very much.
Thank you so much, Dr. Aminu. Please, Dr. Mamodu, go ahead.
Thank you so much. Good morning, our teachers and colleagues. Thank you, Dr. Florence, for the beautiful presentation. I just wanted to entertain some of the concerns Dr. Temi raised. Okay, looking at this picture categorically, we know West Africa tends to put some possible plenty differentials in the sense of you now decoding it. So, Dr. I'll answer it with Dr. Florence's statement initially. For those with obstructive sleep apnea, you said we have obstructive pulmonary lung function. No, it actually depends on the comorbidities the OSA presents with. And typically for those with OSA without all these plenty comorbidities, they have a normal lung spirometry. The OSA does not affect the spirometry. And here in this question, beautifully put, they put a restrictive pattern on what they call it now for the pulmonary lung function test. The possible differentials of the diaphragmatic paralysis, definitely they would have given us maybe some other things, preferably to actually distinguish it or differentiate it. Because the follow-up questions and some of all these 10 questions actually fits into the weekend. And they can present with dyspnea. So the exertional dyspnea aspect of it, I know is one of the common presentations the patients with pulmonary hypertension will present with. But mind you, these people have obesity and also dyspnea. Whenever they get easily tired, they have the exertional dyspnea. So it's not, although they typically will have the symptoms as you actually said, remember, it's a state of chronic hypoventilation. So they can have the exertional dyspnea. Coupled with the, we know that the comorbidities can exist with it, whereby we have OSA always almost mixed with it. So I think for this young male who has this massive BMI, that's morbid obesity, with exertional dyspnea, and a restrictive lung function, OHS should come up top. It's very, very, very sure true that you should exclude. It's a diagnosis of exclusion. You can do your ABG, a weak ABG, which will help. I think that was what they were trying to portray in this question, as in what investigation will you do to make your diagnosis, to actually outline it out, since we know that they can coexist. Then just as Chief Ekele has said, the OSA is an upper airway thing. The central sleep apnea is a brain response, the brain respiratory issues. You mostly see that on the setting of whereby those central receptors are actually, in terms of the brain connection, are getting some poor response. So those with heart failure, typically, you see them coming with central sleep apnea. Those with upper airway obstruction may be coming from the fat. And what really happens there is during sleep, it's during their sleep, when they sleep, not daytime, not awake, there's muscle relaxation and their back, the tongue, most especially the tongue on the upper respiratory muscles become relaxed and closed up those airways. That's why they have, if there's permanent closure of the airways, they have apnea or cessation for 10 seconds. Then if there's reduced airflow, you have the hypopnea. So you can use the obstructive sleep, the polysomnography to actually calculate the AHI, that's the hypopnea, apnea hypopnea index, which you can use to grade severity of the OS. Thank you so much.
Thank you so much. Thank you so much, Dr. Mamodu, for that add-on. And then Dr. Temis is saying obesity on its own without respiratory disease can cause restrictive impairment on spirometry. And then Dr. Adobe saying, thank you for your presentation. CPAP is the primary mode of treatment for OHS cases with concomitant severe OSA. However, in cases where CPAP is ineffective, BiPAP may be used at the onset of treatment due to hypercapnia during acute exacerbation or hospitalization with decompensation. So NIV is the first-line therapy for patients with OHS and no OSA or milder forms of OSA. Thank you so much for that add-on. Exertional dyspnea can be, Dr. Temi is adding, exertional dyspnea can be an angina equivalent. Coronary artery disease is also a strong differential here too. Okay. I think she mentioned, when she was answering the A part of the question, what could cause the symptoms, she also mentioned pulmonary hypertension. That could cause the exertional dyspnea. Well, thank you so much, everyone, for your comments. Those have made comments on the chat and their contributions. Okay, so now I'll hand over to our teachers. Ma Christabel.
Thank you so much, Dr. Bekele. Thank you, Dr. Florence. I must appreciate the respiratory specialists for coming in. Dr. Mamudu, Dr. Temi, Dr. Aminu, Dr. Ada, that's names, then Dr. Ekele herself. I've seen the names I got. If I didn't mention any, please, my apologies. My apologies. We appreciate you. I love the way you guys have thoroughly discussed this question. Thank you so much. I don't know if any of our chiefs have any comments.
Good morning, ma'am. My hand is up already.
Please go ahead. Okay. Go ahead, please. Dr. Success, go ahead.
Thank you so much, Doctor. Thank you so much, Dr. Florence, for the lucid presentation, and then those that contributed. And Florence, maybe you can go back to the question, or maybe it was a recall problem. The first question that you had was, what is the cause of the symptom? I know there was a recall that the first was, what is the diagnosis? And then the second is, what is the cause? So the diagnosis is OHS, then the cause are those ones, that you listed, the obesity itself, the alveolar hypoventilation, the blunted respiratory drive, and then sleep disorders and pulmonary hypertension, amongst others. I want to say that Ekelechi is correct. OSH is more in female, is more in males rather. Is more, while OSA is more in females. Now, I also want to point out that emphysema can also be a differential diagnosis for patients that present with OHs. Then too, Florence, important investigations we're also thinking would have been, fasting lipid profile, and then you want to also check the glycemic level of the patient, which is very, very important. Now, in this patient too, another very important investigation you talked about, which I agree, is a sleep study. Okay, the polysomnography. This is very important because it will actually help to determine the severity of sleep apnea using the AHI, apnea hypopnea index. Those that are going for neurologists or specialties, this is a very important point for you because it comes out in almost all the MCQs. Okay, so you assess the severity of sleep apnea using the apnea hypopnea index. Okay, so this actually categorizes the patients into mild sleep apnea, moderate sleep apnea, and then severe sleep apnea. If the apnea hypopnea index is between 5 to 15 events per hour, that is mild sleep apnea. If the apnea hypopnea index is between 15 to 30 events per hour, that categorizes the patient to moderate sleep apnea. And if it is more than 30 events per hour, it categorizes the patient into severe sleep apnea. I want to also say that one of the distinguishing factors between OHS and OSA, apart from the fact that patients with OHs have daytime hypercapnia. Now, if you do the spirometry in patients with OSA, majority of them will have obstructive pattern, while a few of them will have restrictive. But in the case of OHA, almost all of them will have a restrictive pattern. So this is a very important, one to note. Now, in managing patients with OHA, apart from the fact that it's multidisciplinary, we also have the non-pharmacological aspect, which is very important, the pharmacological aspect, the device therapy, and of course, the surgical interventions, if all this fails. And then it's important to manage complications if they arise. I want to say that the non-pharmacological aspect of managing them is very key, because no matter what you do, if this patient doesn't lose weight, okay, we will not achieve anything. Okay, so weight loss is very important. So you tell a patient, of portion control, diet, exercise, and of course, lifestyle modification. Then a patient is smoking, somebody raised it up. It's important we rehabilitate this patient. Okay, so smoking cessation using the 5 A's, okay, where, the ask, advise, assess, assist, arrange. This is very important. The patient should, as part of the non-pharmacological, should avoid sedatives at night, and then avoid heavy meals at night. All these are small, things we can tell the patient to help patient symptoms. Then when the patient is sleeping, should sleep on the side and then elevate the pillows. They've talked of the pharmacological, and then the oxygen therapy, and then the device therapy. Now, it's important to note that you can also do tracheostomy when all these mechanisms fail. And there are other, surgical interventions, especially for the obesity, okay, like the gastric banding, and then the bariatric surgery for the weight loss. So these are actually my comments. Thank you so much. Thank you, presenter.
Thank
Thank
you.
you, Success. Thank you so much. Thank you. I don't know if there are any comments from our teachers, Chikuki, Bebansi, Chichitu, Remigus, Fatima, Kopi, Dahatu, Ata, Yahaya. Don't know if there are any more comments before we move to the next question.
Well, I have a comment, but until you stop the recording later.
Okay, that's fine. That's fine. Thank you. So
hello?
Oh, go ahead,
Hello?
sir.
Yeah,
Go ahead,
so
sir.
I don't know. I was locked out for a little bit before the Success started talking, but I just wanted to say that sometimes it's not important to overthink these questions, okay? So sometimes the what they tell you is enough. If you look at the way they went ahead to try and rule out a lot of things, you will see that they're trying to make you understand that this the particular diagnosis they're referring to is one of exclusion. No this, no that, no this, no that. Okay, so just trying to tell you that attempts have been made to exclude so many things. Therefore, this particular one is something that requires exclusion. That's something I just wanted to point out. So you need to look out for things like this, okay? Questions that have a lot of no this, no that, no that. They're trying to rule out so many things for you so that it will help you understand that they're trying to make a diagnosis of exclusion. Thank you, my chief. That's just what I wanted to add.
Thank you so much, sir. Thank you. Thank you. Any more comments from our teachers? Okay, so thank you so much, Dr. Kalamama. That was wonderful as always. Thank you. Thank you so much. Thank you. I appreciate your time, the time you took in praying for this. Thank you so much. Dr. Ekele, over to the next presenter.
All right, thank you so much. Dr.
It depends on the question. If it's something that will take time, maybe counseling, education, one of those things that will take time. But I have to move it to tomorrow. It's already 7:43, so we'll handle it properly. I won't rush. Because most time, once we're exceeding our usual time, we tend to rush things. So depending on the presenter. So I don't know who's presenting, Dr. Ekele.
It's Dr. Abdullahi. I think the question is it team? Team. What's the team?
That's straightforward. That's fine. So let's go ahead, please.
Dr. Abdullahi Baba.
Okay, good morning. Good morning.
Good morning.